Hello again, and welcome to this second video of this mini-series on physics of fluoroscopy and ionizing radiation for the FFPMRCA. If you haven't watched the first video, I'll pop it up here. Please have a look at it because what I'll explain today follows through on the knowledge that we've built on in the first video. And if you haven't done so already, don't forget to subscribe to the channel so you can receive notifications on the new videos as they come out. So when it comes to ionizing radiation, there is a term called linear energy transfer, and that just simply means the amount of energy that is transferred from the ionizing radiation, so from the X-rays or the alpha particles, to the medium. And the medium in this case will be the patient or the operator. The units for measuring that is kilo electrovolts. So kilo electrovolts refer to the amount of energy per micrometer. And so per micrometer refers to the area of the medium or the area of the human tissue. If you recall from the previous video, different types of ionizing radiation have different amounts of damage. So some forms can be more damaging than other forms. And that is how we compare them using the linear energy transfer. So ionizing radiation, if it's in the form of alpha particles, that has a very high linear energy transfer. And so the type of damage they cause is direct damage, meaning that when they hit the cells of the body, they can basically destroy the bonds of the DNA, they can destroy the structural integrity of the cell, and they lead to cell death and apoptosis. And if that happens in large enough quantities, that could lead to clinical symptoms and organ failure and possibly death. In contrast, X-rays and gamma rays have a low linear energy transfer, which means that their mechanism of damage is primarily indirect, and that is through the concept of ionization. So basically, when the X-rays and gamma rays hit the cells of the human body, they create unstable ions. Now, because water is the most abundant material in our body, usually the ions are made from water and create hydroxyl ions. And similar to oxygen-free radicals, these are unstable ions and they need to basically react with the body's tissues in order to become more stable. And by doing that, they cause damage. So that's the first way of classifying hazards of radiation through the mechanism of action of the damage itself, either directly or indirectly. The second way is by classifying it through the effect of increasing the dose of radiation. And you can classify that into deterministic or stochastic. Always remember, deterministic starts with a D, so it relates to the dose, which starts with a D, which means that if you increase the dose of radiation, you are increasing the severity of the injury. So an example of that is burns. If you increase the dose of radiation, you will get more severe burns. Stochastic relates to the probability of getting the injury, but it doesn't relate to the severity. So if you increase the dose of radiation, you are more likely to get the injury, but it doesn't affect how severe the injury is. And a good example of that is the cancer risk. So if you get a chest x-ray, your lifetime risk of getting cancer is 1 in a million. If you get a CT of your abdomen and pelvis, your lifetime risk of getting a cancer decreases to 1 in 2,500. But that has nothing to do with the severity of the cancer itself, because all you need is one cell to become neoplastic to get a cancer. And finally, the last way of classifying the hazards of radiation is through clinical effect into acute and chronic. So acute symptoms would be, for example, nausea, vomiting, gastrointestinal symptoms, seizures, CNS symptoms, and chronic effects would be carcinogenesis and infertility. Now, this slide builds on theoretical knowledge we've discussed in the first video, so it's a good way to see if you can still remember the basic science. So if you recall, one of the ways of measuring radiation is through absorbed dose, and the unit of that is, yep, that's correct. So that's gray, and that's just basically the plain amount of radiation that is absorbed. It doesn't factor for anything else. But then you've got another measure called the effective dose, which is measured in millisieverts, and that basically accounts for the type of tissue being irradiated. And so that just reflects the idea that some tissue is more sensitive to radiation, so is more likely to be injured than other tissue. And what determines that is the rate of cell division. So if you have cells that divide all of the time, you will basically get a very high tissue sensitivity. And so they will be the ones most prone to injury. And so they will need much less irradiation to produce symptoms. And if you look at the slide, it makes sense that the bone marrow cells, the hematopoietic cells, are the ones that are most at risk of injury. So things like pancytopenias, bone marrow failure, will be relatively common to happen with lower doses, followed by the reproductive organs, followed by the gastrointestinal system. And then you have more tissues which are more stable and so less likely to be damaged, which are the cells of the nervous system. And so to build on that, it also makes sense that the growing fetus, so if someone's pregnant, they're at risk and have very highly sensitive tissues because essentially that's cells that are dividing very, very quickly and growing. And so, if you get irradiated during pregnancy, or the fetus gets irradiated in the first couple of weeks, that's usually before any organogenesis. So, if you get an effect, usually it will be intrauterine fetal death. And then, after a couple of weeks, you get organogenesis. So, in the first few weeks after that, that's probably the highest risk where you get issues with early onset cancers, growth retardation, and so on. And then as the fetus becomes more developed, that risk becomes a little bit lower. So you need higher doses to produce the same effect. And what all of this boils down to is that ionizing radiation is dangerous. It has real and serious side effects, and it is something that we need to be mindful of and fully understand in order to minimize the risks for ourselves and for our patients. But it is also a part of the informed consent process. If you're doing an interventional pain procedure, you need to consent your patient for radiation risk, and you need to be able to talk in a little bit more of detail about that type of risk. I certainly had a patient before who kind of asked me, well, what do you mean by radiation risk? What risk am I exposed to? And I realized at that point in time that I didn't have a good answer to that. So it's something that you need to kind of, have a little bit of background knowledge on. And because it is something that has risk, obviously there will be regulations for that. The main two are the IRR 99. 99 just refers to the year it was produced, so 1999. So that is the ionizing radiation regulations. And the other one is IRMR, which you will recognize if you do your mandatory trust induction. It is something that everyone has to go through if they are dealing with ionizing radiation or requesting scans or requesting procedures. So yeah, IRMA refers to the regulations that are put in place to try and minimize exposure to the patients. So it's basically about justifying the use of ionizing radiation. And IRR are there in place in order to regulate the exposure to people or workers that are dealing with ionizing radiation. So, pain physicians, radiographers, radiologists, and so on. And basically, both of these regulations use the acronym ALARP, as low as reasonably possible, which just means, as it says, you try and use the minimum amount of radiation you need, and you need to justify using that amount. And if you open these regulations, you'll find all sorts of numbers, but probably for the exam, you only need to know two of those. The first one is the annual dose limit for classified workers, who are basically workers that are exposed to ionizing radiation, and that is 20 millisieverts per year. And the other one is the dose limit for pregnant workers, and that should be less than 1 millisieverts throughout the whole of pregnancy. All right, so let's do a few MCQ questions. For the first question, it says the lifetime risk of cancer is likely to be. This is a multiple true false question. So if you could pause the video for a moment, have a think about it, and then we'll go to the answers. Okay, so I've intentionally put this question in to show you that just by a little bit of thinking and a bit of guesswork, you can probably get most of the answers correct. And this is actually to practice also some of the exam technique. So we'll go through the answers. For A, 1 in a million after a chest X-ray. Even if you don't know the figure, you are aware that the likelihood of a chest X-ray causing damage is pretty minimal. So it is probably likely that the probability of getting cancer from a chest X-ray is very low. So if I were a guessing man, I would say that 1 in a million is probably a true answer. Let's go to B. Greater after a skull X-ray than after chest X-ray. Again, if you remember from the first video, the more bones there are in the X-ray, the higher penetration you need, and so you need a higher dose. And so if you have a higher dose of radiation, the probability of cancer is going to be higher, which makes B false just by using your knowledge. For C, lower after an abdominal X-ray than a skull X-ray. Again, if you think about it, when you're taking an X-ray of the abdomen, you've got a couple of things. You've got probably the thoracic vertebrae and the lumbar vertebrae, so that's quite a lot of bony material. And you've also got a lot of the abdominal contents. And if you remember from the tissue sensitivity, the gastrointestinal system is quite sensitive to radiation. So both of these factors probably make an abdominal X-ray slightly more dangerous when it comes to cancer risk compared to a skull X-ray, and so that'll be false. For D, increased in children who are exposed to ionizing radiation in utero. That's common sense, so it'll be true. And finally, lower after a chest CT compared to a chest X-ray. That is obviously wrong. A CT is always going to have a higher dose of radiation to an X-ray, and so a higher risk of cancer. So let's move on to the next question, which is an extended matching question. And again, it is deliberately hard just to try and sort of, use a little bit of exam technique to narrow down some of the answers. So if you don't actually know the answer, you can probably try and get most of it correctly still. So with extending matching questions, basically each option might be used once, more than once, or none at all. So more than one question could have the same answer. And so basically, this relates to the radiation dose and the clinical effects we get from that. So the first stem is saying a pain physician dosimeter detects an exposure during a monthly check. The physician has no symptoms at all. And so, what is the sort of range of absorbed radiation dose that we would expect? I'll let you think about it for a second before we go to the answer. Okay, so this is actually a very hard question, but I think the key to answering it lies in your ability to try and reflect on your daily practice when you're utilizing fluoroscopy. So, if you remember, when you look at the measurements that show up at the end of your procedure, there is something called the dose area product, and that's usually in gray meter squared. And that's usually something actually that is 0.00 something milligrays for your whole procedure. So basically, if a pain physician's dosimeter detects some exposure and has no symptoms at all, they will very likely not have a number that is in whole grays. It is likely going to be something less than 1. So we're actually looking between choices A and B. And again, if I were just a guessing man, I'd probably go for the lowest dose, A, which is actually the correct answer. Okay, the second stem is talking about a worker who is accidentally exposed to a source handling incident and developed some transient gastrointestinal symptoms and some drop in their lymphocyte counts, but then they've recovered on their own accord without any treatment. So have a think about the answer and we'll go through it together in just a moment. Okay, so basically, again, if you try and do a little bit of guesswork and a little bit of thinking, in your day-to-day practice, you know that the patient's exposure is in the region of milligrays, which means that it's less than 1, and they typically have no symptoms at all. So if you're developing some mild symptoms, then you're in a slightly higher range above milligrays. So potentially maybe a little bit more than 1, but you know that the options E, F, and G seem to be very high, sort of, getting 10 to 20 gray or more than 20 gray seems quite a lot. So actually, you're probably thinking between C and D. And if I'm going to guess here, because this patient just recovered on their own, they didn't need any treatment, I'm probably going to go for C, the lesser one of both of them, which is the correct answer in this case. Fine. For this case, this worker was exposed to an extremely high dose and they've developed confusion, ataxia, and seizures. So you're starting to get central nervous system symptoms here. And then they actually died 24 to 48 hours later. So obviously, your answer here is going to be in a slightly higher range. Have a think about it, and then we'll answer it together. Okay, so out of all of these, we're not expecting them to be A, B, C, or D because these are just sort of, much smaller number. And if you look at G, that's quite a high number. That's sort of, the outlier from all of the numbers. So actually, we're looking here between E and F. So if you're taking a guess, you've got a 50-50% chance. The answer here actually is F, greater than 20 gray, and that is because they had central nervous system symptoms. So if you remember, the central nervous system is relatively resistant to radiation, so you actually need quite a high dose to start having symptoms. All right, so question number 4. Following a major radiation incident, a patient develops profuse bloody diarrhea with evidence of gastrointestinal mucosal sloughing and overwhelming sepsis. Despite maximal treatment in intensive care, they die within 2 weeks. So, if you think about it, in the same question, we've got a couple of patients who die. One of them dies immediately in the first couple of days, and the other one dies within a couple of weeks. And so, by exclusion, again, we're ruling out probably A, B, C, and D. These are all numbers in single figures. They're unlikely to cause death. And we're ruling out G because that number is just an outlier. We've got 1,000 gray, which is an outlier to all of the other options. So again, I'm choosing between E and F. And so I'd probably just by guesswork, the patient who dies within 2 weeks will probably need less exposure. So that will be option E, 10 to 20 gray, which is the correct answer. And the previous patient who died within 24 hours will be option F. And finally, for the last STEM, a patient exposed during an incident develops vomiting within hours, followed by pancytopenia, requiring transfusion and prophylactic antibiotics with ICU care. And they considered and actually proceeded to a bone marrow transplantation. And after that, the patient survives. So basically, this is the patient who had some serious damage but survived secondary to a bone marrow transplant. And again, you're basically ruling out the very high figures and the very low figures. So you're looking at something in the middle, which will potentially be D or E. And in this case, the correct answer is actually D, 1.5 to 10 grays. And so this is a table that summarizes the absorbed dose in gray. So actually exposed dose is the wrong terminology here. This should say absorbed dose and the effect. And so at lower effects, you don't need to study this in detail, but what you need to know is basically death can happen from radiation, and death usually happens in 2 weeks for 100% of the patients in a dose above 10 gray. And if it is above 20 gray, you basically get CNS failure. And then at the lower doses, you start getting gastrointestinal symptoms. And so that's the end of this video. For the next video, we'll actually focus on the practical safety aspects when it comes to reducing the radiation doses for workers as well as for the patients. So I'll see you then.